Good evening, everyone. Thank you for joining us for this informative webinar tonight. My name is Stavroula Savelidis, and I'm the Executive Director of the Nassau County Medical Society and the Nassau Academy of Medicine. A few housekeeping tips for tonight's presentation. Everyone will be on mute during the presentation. If you'd like to pose a question, please type it in the chat box or the QA box, and we will ask our speaker to answer the questions as they come in. Our speaker for tonight's webinar is Dr. Edward Rubin. Dr. Rubin specializes in the treatment of chronic pain of the low back and neck and muscle pain related to sports injuries. He works in collaboration with orthopedic surgeons in managing pain in the joints and spine. Dr. Rubin's philosophy is to put patients first. He uses the most up-to-date research to tailor each treatment plan based on individual needs. Dr. Rubin offers expertise in providing a wide range of treatment modalities, including non-invasive laser therapy, medication management, and the most cutting-edge interventional techniques. Dr. Rubin emphasizes the use of non-narcotic techniques when appropriate. Prior to joining North Shore LIJ and then Winthrop Hospital, Dr. Rubin was on staff for 3 years at Weill Cornell Medical Center in Manhattan. Dr. Rubin completed a fellowship in pain medicine at Weill Cornell Medical College. He also trained at Columbia University, the Hospital for Special Surgery, and Memorial Sloan Kettering Cancer Center. He's board certified by the American Board of Anesthesiologists and completed his residency in anesthesiology at New York Presbyterian Hospital at the Weill Cornell campus. Dr. Rubin received his medical degree from St. George's University School of Medicine in Granada in 2001. Without any further delay, we welcome Dr. Rubin.
Thank you for that introduction, and I wanted to thank the Nassau County Medical Society for inviting me to give this presentation, and happy to answer questions as we go, so feel free to throw that out there. So we're going to be talking about telemedicine, and specifically now we have patients that are being seen online and getting controlled substances, and how we're going to handle that. You know, telemedicine is clearly growing exponentially thanks to COVID. Even pre-COVID, they were predicting a growth rate in telemedicine of about 18-ish% a year. And in 2015, there were about 800,000 online consultations. As you guys probably know, it wasn't really billable until COVID hit, unless you met some very specific circumstances. In trying to research this post-COVID, the only data I found that came out from last year was that now about 30% of all outpatient visits are being done on telemed. So odds are you're going to come across somebody that either needs a benzo, an opioid, or some other form of controlled substance. And how are you going to handle that in the context of doing an online visit and stay compliant? So, you know, with the controlled substances, you got really 3 options. You can force them to come in person every month, which is getting a little easier now that there's vaccines and people are feeling more comfortable. Option 2 is just, well, everybody's comfortable on telemed, easy for me, easy for them, keep on prescribing online. Not recommending option 2 as the best strategy. You can make an argument for a hybrid model. I mean, look, there's people that are stable, that are on controlled substances, they're being seen every month, or at least they were. You know, maybe there's some leeway here where you do an in-person visit and then every other, every third, you know, like you can alternate between the televisits and the in-person, but it's going to come up if you do any amount of controlled prescribing, you know, even testosterone, those kinds of medications, sleeping pills, Ambien, you know, there's going to come a time where you may need to do an online script. So how do you set yourself up to be compliant? I mean, my big take home here is just set up a compliant practice, period, whether you're on telemed or not, and apply those principles across the practice. And whether you're seeing them virtually or in person, you have a compliant way of doing controlled substances. And that's kind of the strategy that I'm going to put forth. So just to reiterate, like, what is a controlled substance? So in the US, everything's broken down into Schedule 1. It does go through Schedule 5. I listed some of the common ones here. I know federally, marijuana is still a Schedule 1. I know in reality, in a lot of states, it's considered legal on the state level. We'll get into that more in a minute. Schedule 2s are considered more of your typical like opioids, methadone, oxycodone, and your amphetamine medications. Cocaine is technically a Schedule 2, but outside of using it in ear, nose, and throat surgery, that's really not something you're going to be prescribing on a televisit. And then even some of the steroid, testosterone, those kinds of medications are scheduled, as well as the sleeping pill. So it's not just opioids that we're talking about here. There's a lot of controlled substances, and you're going to want to stay compliant. So Schedule 1s are, typically illicit. Again, marijuana. At the state level, there's a pretty permissive stance. They just even recently got more permissive on marijuana in terms of how much you can possess. Now you can grow it. Federally, it's still a Schedule 1, but you're going to need a strategy if you are writing for medical marijuana cards to have a compliant strategy there. So the most typical stuff we're going to see on televisits is going to be the opioids, sedative medications like benzos, sleeping pills, and some of the muscle relaxers. And don't forget some of the anabolic steroids like testosterone are also considered controlled. So, before you run out and worry too much, like I said, you really just need a solid foundation for prescribing in general. And if you can set that up, then whether it's in person or remote, you're going to be compliant. I put a link to the MISNI website down there, and Stav said that we can archive these slides if anybody wants them, and I also have a couple other documents that we can give people access to if they want after the fact. So nothing proprietary here, happy to share all of my stuff. So MISNI has done quite a bit of work on compliant opioid prescribing. And they basically went through all the guidelines I've listed here and given us some parameters to work with. And the summary of responsible prescribing is mostly pretty common sense type stuff. And these elements that they put forth are really found across all the guidelines. So everything here was mentioned in some way in all of the guidelines that they reviewed. So at least for a new patient, and we'll talk about the physical exam part because that's the big wrinkle with telemed, but for starting an opioid, a physical exam, a pain history, past medical, family, social, pretty basic stuff if you're doing any office visit, period, stuff you would get if you're interviewing a patient. Pretty much all the guidelines talk about doing urine drug testing. I will say right now, if you're not doing some form of urine drug testing, and I'll get more in the weeds on that in a minute, I would say, you're outside the box if you're doing controlleds and aren't testing. And I'll talk more about that in a minute. Have you looked at other options before you pulled the trigger on a controlled substance? Have you documented what other things they've done? Have you said whether or not they're effective or not? When you do decide to start something and you think it is the right decision for that patient, are you starting on the lowest effective dose you can get away with? Do you have a pain treatment agreement or an opioid agreement? I'm happy to share mine with you guys. I think I gave Stav the files on that as well. So anybody that wants a free opioid agreement, you're welcome to have it. Are you monitoring their treatment and their progress? Are you documenting, especially if they're at high dosages? And do you have a plan for discontinuing opioids? Like sometimes we create monsters and we don't mean to, we have good intentions, but you know, there's a percentage of people that are gonna go off the rails and you start getting stories, I ran out early, I need a stronger dose, it's not working. You know, so what protocols do you have to help wean them off? Do you do Suboxone? Do you have somebody you can refer them to? So, you know, you should be able to unwind it, not just start it. So specifically on the issue of opioids and physical exam, just so you know, New York is one of the few 9 states that actually does not have a physical exam requirement for prescribing an opioid. Now, I would say on an initial visit, you best do a physical exam. But now we're in the virtual world and we're doing a virtual visit. You could argue that there's some exam things you could do over video. It's obviously not as good as an in-person exam, but you don't have to document nothing. You know, you can check their gait, you can, you know, see if there's any swelling. I mean, there's things you can document on a televisit, not as good as in person, but just so you know, technically in New York, a physical exam is not a requirement. New Jersey, there is a requirement for a physical exam. So I don't think we have too many Jersey people on the call, but if there are, make sure you are documenting some sort of physical exam. An initial encounter. So if you're doing a controlled substance and it's an initial visit, and this has come up with me, so I have an agreement with a number of the surgeons at NYU Winthrop or NYU Long Island, whatever you want to call the hospital now, that I do some of their post-op medication management. Usually like the harder patients where they need a little extra guidance. Now, you know, it's the middle of COVID, these people had emergency surgery, they're, you know, in a neck brace, they can't drive, like there's COVID. So there were a few scenarios where I had to take over, you know, an opioid patient for the first time on a televisit. So make sure you're documenting, you know, why it is you're doing this. I mean, it's all about context, right? If the context is I'm the guy who does post-op consultations and the surgeon requested me to get involved because it was a complicated case, you know, that's a reasonable context for doing a televisit and writing a script. And then you get them in as soon as it's reasonable to get them in for an in-person exam. You know, versus like I advertised on Facebook and like, you know, like these Roman.com, like where you're going to get a doc that 99.99% of the time is going to give you Viagra. You know, that's a little different context in terms of what kind of meaningful patient relationship you have there. Some things you can do in advance with these patients. So I use the Opioid Risk tool. It's a quick screening thing. I'll show you a slide on that. So risk stratifying patients is going to show, you know, that you're not just willy-nilly prescribing, that you're looking to see if there's really, you know, any risk factors out there you should watch out for. 100% of my patients on a controlled substance have an opioid agreement. It's specifically called an agreement, not a contract. Basically, an agreement gives you all the leverage. If you sign a contract with a patient, well, that's a two-way street and puts some of the onus on you. So by keeping the language as an agreement, it basically says they have to use the medication as prescribed, they have to agree to urine drug tests. So it sets the expectation of what, you know, the patient is responsible for on their end. Then the last thing is, you know, counseling and doing an informed consent. Again, you guys are welcome to copy mine. Funny thing is I do chart reviews for, you know, legal stuff for pain management, and I've seen my exact thing there show up in other people's charts that I've reviewed. So this is floating around out there. Again, it's fair game. I don't think it's proprietary, but essentially it lays out that we've counseled the patient. We've told them that these things can be habit forming. I know that's come back to bite people in the ass before, that, oh, the patient got hooked on pain meds. You never told them they could get hooked on pain meds. And yeah, it's obvious for anyone that's been watching the news the last 3 years that you could get hooked on oxycodone. But, documentation is really what matters. I put in there that driving is, the patient's responsibility. It's kind of hard to say like nobody can drive on a pain medication. So it kind of takes the onus off of you. And we kind of wrap it up with, that we've talked about the goal being to wean off opioids. I've answered their questions. They understand the accountability on their part. And then the last sentence is important. Medical legally, patient has a generally accepted medical condition that warrants treatment with opioid medication. That's the one where, all the people that are on the cover of Newsday that have gotten in trouble with prescribing, basically the government said you were not treating these people for a generally accepted medical condition, that you were just kind of willy-nilly, prescribing. So all this language is important to cover you. This is the opioid risk tool. Obviously, when the patient does it, you don't have the scoring on there, otherwise they'll see that they're getting a high score. But it asks about, family history of substance abuse, personal history of substance abuse, and then there's some other age, sexual abuse, psychological stuff. So very simple checkbox kind of thing. Patient can fill this out in like under 30 seconds. And, for the most part, it's meant to cover your butt that they're a low risk person of abusing. But occasionally you'll get some high risk people, and you'll need to maybe be extra careful with people that are high risk. When it comes to documenting in your follow-ups, like what sort of things should be in your notes to keep you compliant. This is, again, a little specific to the opioid crowd, but there's the 4 A's of pain management: analgesia, activities of daily living, adverse events, and aberrant behavior. So, what's their pain score? That's the analgesia. Activities of daily living, what are they able to do or not able to do? For low back pain patients, I use an Oswestry Disability Index. It's basically a rating system scale that you can use for patients with low back pain. In essence, to say like, how messed up are you? The higher the score, the worse you are. So if you have somebody with a very bad Oswestry and you're giving them meds, it kind of justifies what you're doing. Adverse events you should be looking for: sedation, constipation, typical side effect type things. And then aberrant behavior is, are they running out early? Are they having abnormal urine tests? So hopefully you're documenting that there's no aberrant behavior. Now there is a form, it's called the PADT form. Again, it's online, I shared it. This was designed by Janssen Pharmaceuticals. It's actually required for workers' comp if you're treating patients with opioids. It's supposed to be filled out by the physician with the patient. But for the most part, you could have the patients do what they can and then fill in your parts afterwards. But like this in and of itself gives you everything you need for a pain note. Now I know with EMRs, like it could be duplicate work, or you could scan this in. That's what I do. So I have my own EMR note. There's a page 2 here that goes through the side effects and any aberrant behavior. So this is like a 2-page fits all everything form to cover you. And then at the end, it says like, what's your plan? So another part of New York State specifically is you have to have a plan in every note with your opioids, and that's important as well. So again, the opioid treatment plan is a required element in New York State. They passed that about a year ago. So technically, every time you write an opioid, you need an opioid treatment plan. I've given you a generic one here that kind of fits all. Patient remains on opioid medication for chronic pain. Patient remains within CDC guidelines. We'll talk about that in a minute. Plan to continue current regimen for palliative relief of chronic pain and to maintain functionality and ability to perform activities of daily living. So there's a plan. You can cut and paste that into your notes, assuming it's accurate. And with the CDC guidelines, essentially, it's 100 morphine equivalents a day, which is about 60 milligrams of oxycodone a day. I would imagine outside of pain specialists, most people aren't writing more than 60 milligrams a day of oxy for a patient. I also add specific language for televisits. My understanding is this is going to become kind of a required thing to get paid on telemed in the future. So it basically just says that this was interactive, live video and audio, that it was from my practice to the patient's residence, that the patient consented to video visit, and that I confirmed who they were with their picture on file. So even if you're doing televisits for anything else and has nothing to do with opioids, start putting this language in your notes, because the carriers are going to start looking to make sure you're documenting this so that you're not fudging it, that you called them on the phone and you billed a televisit when really it needs to be live video audio. All right, I'm going to go through, not in horrendous detail, but I want to touch on the CDC guidelines. Everybody references these. The payers latched on to these guidelines. They came out, I believe, in 2017. The purpose of the CDC guidelines was really more like a warning to the internists not to, push dosages above 100 morphine equivalents. It got adopted by a lot of the payers. It got adopted by workers' comp. It kind of became like an excuse to not allow stuff, which was troublesome for pain specialists, because obviously we're not, prescribing the same way an internist would, and we're stuck with, a lot more challenging patients, a lot of legacy patients, from the 90s and 2000s. But here are the big take homes. Now, this is what's on the CDC website now, and you could see they kind of, didn't focus too much on the dosage language. It's in there, but really the focus is about, making sure opioids aren't your first line therapy. Obviously, for pain, you want to try other modalities first. It could be an NSAID, physical therapy, cognitive behavioral. For me, I'm all about doing spine injections. So if you come to me, I'm not, straight out writing you for an opioid. Now, post-operative, yeah, it's an opioid. That's what's indicated. But outside of a fresh post-op patients, which most of you are not dealing with, you want to make sure you try simple stuff first. Having the goals and, describing what it is, you want the patient to be able to get out of the opioid treatment. You should be able to walk further. You should be able to do more. If you're just taking opioids and sitting on the couch all day, that's not really improving your quality of life. Versus, I have professionals, people that are lawyers and other things, if they didn't have, their morphine pills a day, they wouldn't be able to, go to work. So there are people out there, we've kind of demonized them, but there are people out there that are functional on their opioids because of their opioids, but you need to document that that's the goal. Again, informed consent, going over risks and benefits, needs to be discussed and documented. In the past, there was, talk about the long actings being better than the short actings. The recommendations are to start with immediate release medication and to basically start with the lowest effective dose. The decision to go over 90 to 100 morphine equivalents a day, should not be taken lightly. There's online calculators for that, but it's about 60 milligrams of oxycodone is roughly equal to 90 to 100 morphine equivalents. Do short durations of medication. So initial scripts, 7 days. No reason to be writing, big quantities for the first script. So you do a 7-day, you make sure they tolerate it, that you're getting the expected response, and then you can do more than 7 days if you feel it warrants it. Constantly look to evaluate if it's beneficial versus harming them. The PADT form is helpful for that. And then, having strategies to risk stratify people is important. I gave you the Opioid Risk tool to look at who could be a high-risk patient. It's the law that you got to review the PMP, some people call it I-stop. But if you're writing opioids and you're not looking on there, I mean, it's a felony with a $1,000 fine per occurrence. So not something you want to get caught failing on that one. I mean, you can delegate it. And again, this was a MISNY win. When the law first came out, it said that the physician specifically, or the practitioner, had to be the one checking the database. And then MISNY stepped in, they got them to dial down the language. So I have a medical assistant who screens all the I-stops for the day. I'm gonna touch again on urine drug testing. My opinion, based on everything that's out there now with CDC guidelines, best practices, if you're writing controlleds, and even if they're just benzos, which seems to have flown under the radar, a lot more than the opioids, like, you really should be urine drug testing. The patients that are compliant should have nothing to hide. And so it shouldn't be an issue. There's like fear with some physicians, like, oh, I'm gonna upset my patients by doing a urine drug test. I don't think so. My patients aren't upset. It's just part of the deal with being on a controlled substance. That's fine. You don't want to do testing, just don't be on a controlled substance. I'll do shots, I'll write non-controlleds, and then you don't have to do any drug testing. Personally, I don't test for marijuana because there are people that take it medically. I feel like it just creates more of a headache for me because there are people that, are using it for medicinal purposes. If anybody needs a urine drug testing setup, I have a whole turnkey thing I can share with you guys, but I can't emphasize enough, if you're doing controlled and you're not testing patients, you're officially outside the box at this point in the game. Avoiding opioids and benzos, this is like probably my #1 headache right now. There seems to be a lot of people on both. There was just an article that came out, I believe it was yesterday or the day before, that said even though the CDC guidelines came out, the number of people on both opioids and benzos has not gone down at all. So these guidelines have been out. The data on this came from a study where people who landed in the ER with an overdose, if they are on benzos and opioids, their risk of death was 10 times higher than if they were just on opioids. So that was kind of the study that pushed this, saying, look, if people are on both and they overdose, 10 times higher chance of dying. So I have a big issue where I have people that are on benzos, they're on opioids, I'm counseling them, they shouldn't take both, but that's kind of the best I can do right now, other than pulling the rug out from under them and saying you have to pick one or the other. But I'm very vigilant on my documentation. If somebody's on both medications, I counseled them. I told them to take the lowest possible dose of a benzo and preferably to get off. And then last point, offering, treatment for opioid misuse. So, I mean, I don't take Suboxone patients off the street, but if I create a monster, then I'm more than happy to get them off opioids. And a lot of time it's a family member, like, the patient's kind of hiding it from me and doing a good job of playing like everything's okay. And then the family member calls me up and says, dude, we have a problem here. They're taking all their meds, they're running out a week early, they're not telling you. So for those patients, I put them on Suboxone. There was a study that came out last week basically saying that for long-term chronic pain, that buprenorphine, which is the molecule for Suboxone, is actually a better long-term, safer long-term opioid than oxycodone. Now, I know buprenorphine requires a special license to prescribe it. Obviously, I have that, but there's the same molecule in the form of Belbuca, Butrans patches. So this molecule has been repurposed as a acute/chronic pain medication. So there are formulations out there that you can write for, but I do like buprenorphine for long-term use. The main advantage of buprenorphine is it has a ceiling effect. So like a normal opioid, dose effect is just going to keep going up. You basically hit a ceiling with Suboxone. So as long as you're not mixing it with a benzo, you could take a whole bottle of Suboxone. You're not going to overdose because it has a ceiling effect. Now, that's not true if you mix it with another molecule like an alcohol or a benzo. Then you could get into trouble even with buprenorphine, but by itself, it's pretty hard to overdose on. So for more challenging patients or people who, in my opinion, need to lose their opioid privileges, I put them on buprenorphine. So how can you make your life easier in dealing with controlled substances in your practice? Going through all that stuff I just went over in the last half hour, you might not have time to do all that in your 7-minute telemed visit. So I have a medical assistant in my office, or maybe you feel more comfortable with a nurse, but I have basically in my office, it's an opioid compliance officer. I kind of generalized it to controlled substance, but pick one person and make them own, all the back end work of keeping you safe. And the rationale is you want to keep me safe because you like to be employed. So you don't want me to be in trouble. So help me to stay out of trouble and help police the practice. So I have one staff member, they literally run through everybody I'm seeing that day, even if it's just for an epidural injection. So we know that all the eye stops are on file. Anybody who's on a benzo that probably didn't tell me or I didn't even know, now I see it. Any multiple prescribers, they're gonna flag it. So I get a list every day of names of people that are flagged based on eye stop. Now it might be innocent, there might be nothing wrong with what they did. I have a lot of patients go for surgery. A surgeon wrote them for a script after surgery, and now they're coming back to me. So, okay, that's why you have another prescriber. Just document that. But, having somebody flagging all this stuff is going to prevent you from missing. My opioid compliance person also picks who's doing urine toxicology. In my practice, I'm testing quarterly for the majority of patients. So that's 3 to 4 tests a year per patient. A little off the topic, but urine toxicology is a CLIA waived thing you can do in the office. It's billable. So I would argue that the reimbursement from doing the urine screens pretty much funds the opioid compliance position. So it kind of pays for itself. It also takes the urine toxicology off of my plate as far as picking and choosing who to test on a particular day. Obviously, if I have a concern, I'll say test this person. But it just allows me to say, hey, look, I'm not picking on you. It's just protocol. And that way it doesn't look like you're giving them a hard time. And then that person's going to follow up and file all these urine tox results so that, you make sure they're on file. The way we do it is we do a point of care cup, like I said, that's billable. Then I send it out to a reference lab to confirm, so I don't jump to conclusions on the point of care test. But then I get the official results from the laboratory. So for urine testing, I mean, high risk people, you know, I'm testing them at least 4 times a year. There's people I'll test monthly if they've given me a hard time for some reason. Medium risk people, which is the majority, you know, we're testing 2 to 4 times a year. If they're low risk, you know, 94-year-old that takes 1 Vicodin at night because when she lays flat, her spinal stenosis gives her a lot of pain. All right, fine, you know, test that person once or twice just to be compliant. You need a process for this whole urine toxicology business. Like I said, you can do it where you do point of care in your office. For me, like if you're doing 5 of these tests a day, I would say it pays to do it in the office and then send it out to a professional lab for confirmation. If you're less than 5 people a day getting a controlled substance, you can outsource it to Quest or one of those labs. The problem with Quest is you're handing them a piece of paper saying, go take a drug test. So they could slow walk that, you know, for 3 days, and whatever cocaine they did on the weekend isn't going to show up in their urine by the time they, you know, get to Quest. So doing it in-house, they don't know. They could guess when they're getting it done. But, you know, if you say go pee in the cup, there's no weaseling out of that. And for people who can't pee in the cup, there is an oral test that also, it's not billable like the point of care, but for people that swear, oh, I just went to the bathroom, I can't do it. Okay, no problem. Just put this under your tongue for 30 seconds and we'll send off an oral test. So the technology's there. Couple more tips. I believe this is my last slide, but really try not to do stuff outside of state lines. I've made a couple exceptions for snowbirds that are like going to Florida for 3 months and coming back. But it's not a good look if you're writing a lot of controls all around the country. That'll definitely get you flagged and potentially make an issue. Really, telemed for controlled substances, in my opinion, should be for long-standing patients, people you know that you have a good track record with. Now, going back for 1 sec to the urine toxicology, some practitioners will argue, I know my patients and they're long-standing patients, I don't need to drug test them. You have no idea what you don't know. And until you test people, like, you're not gonna find out these things. And let me tell you that probably 90% of your headaches are like 10% of your practice. And these urine drug tests that end up getting people kicked out, like, it's amazing how much they're in the 10% of the people that are headaches. So by using the urine tox to weed out the bad apples, I've found that, you know, the 10% of headaches keeps dwindling along with the headaches that went with them. So there's some usefulness to that. But the bottom line is, if you're doing telemed and writing these things, you should have some sort of meaningful patient relationship. That's really the standard that you're being held to if they're going to come and pull back the curtain and look through your notes. You know, refresh your agreements periodically. So usually every 3rd year or so, I'll basically, everybody who comes through will re-up the opioid agreement. They'll re-up a lot of the forms for the practice, just to make sure, you know, somebody says, oh, I signed that thing in 2010. How was I supposed to remember that I, you know, shouldn't sell my medication? Well, you probably shouldn't have done that, but by refreshing it periodically, there's no excuse on the patient's part. So, if anybody has any questions, I'm probably a little short, but we'll leave 15, 20 minutes. I don't know who's got questions, but happy to field them. Alexa, I'll defer to you.
We do already have one question in the Q&A box. It says, if patient is stable long-term on opiate for chronic condition such as rheumatoid arthritis or cancer, is it acceptable to have post-office follow-up every 3 months with medication renewed without office visit for the 2 months between every 3 to 4 month office visit? Many patients are very hesitant to a monthly office visit for renewals.
Understood. I agree. So yes, I would say, every 3rd month in person is reasonable. The guidelines in New York State, I did mention there was no physical exam requirement, but there is a 90-day requirement that you shouldn't be writing for more than 90 days without seeing the patient. When they wrote the language back then, it didn't say see the patient online or see the patient in person. But what I'm doing, so there was, the worst of COVID, where probably a big chunk of people got the better part of a year of just doing online. But what I'm changing the practice to now is that you have to be seen every 90 days. So I'm giving them 2 months a televisit and then 1 month in person. So I think that's reasonable. Again, these are people you have a meaningful patient relationship with, that you've known over a period of time. So not people that just found you on the internet in Texas and want you to write a script for them. So 90 days is the New York State regulation.
Thank you, Dr. Rubin. We have another question. It says, when doing urine testing, do you have your patients sign a document prior to submitting the sample? If so, what does this document look like?
So the answer is yes, they have to consent to the test. There's chain of custody issues with these kinds of urine drug tests. So the form that they sign is really a form that the lab made for me. But yes, they have to consent to the test, and then they put like a seal over the top and they sign it, and that proves that nobody opened the cup or tampered with it. So there are some chain of custody issues with doing urine drug testing, but short answer is sign the form, put the label over the top of the cup, which seals it, they sign it, and then when the lab gets it, they can verify it hasn't been tampered with.
Thank you, Dr. Rubin. If there are any other questions, you can drop them in the chat box or in the Q&A box down below.
And then for you guys, I guess, so I put the PADT, the opioid risk tool, I put my medical legal statements and a few other things. I put my policies for how we do testing in opioids. So I gave all that stuff to the society, and I will let them explain how you can access any of that stuff. If you want it, I'm happy to share. Stav, is there a process on your guys' end as far as people who want access?
Yes, we have the documents, the 3 documents you gave us, they're in the Dropbox, and Alexa shared that Dropbox link with everybody so they could get it from there. But if anybody, is having any issues, they could definitely reach out to us at the society, and we'll definitely get it to them, of course.
Okay.
Absolutely. Looks like we have 2 more questions. The first one is, to my knowledge, they have dropped the requirement to have a license in multiple states in order to use telemedicine for a patient in another state. Can you please speak to this?
So I agree with that statement. You don't, like, I have patients in Florida. I don't need to be licensed in Florida to send them the script from New York, as long as I'm practicing in New York. But I would counsel you to not do too many out-of-state prescriptions for controlled substances, because all it's going to take is like one pharmacist in some other state to flag you with the DEA because they don't like what you wrote, to open a whole can of worms. So is it legal to do an out-of-state televisit and prescribe? Yes. I would try and avoid it as much as possible and just stick with in your state, especially for controlled substance.
Thank you, Dr. Rubin. The second question is, can you comment on legality of initiation of controlled substance at initial visit via telehealth? Example, Kisimia/phentermine for obesity.
I mean, that's not an opioid. I think it's reasonable. The expectation should be that you're doing that visit online for a reason and that you have a plan to, you know, get them in for an exam. The examples I gave were, you know, during COVID, I had these post-operative patients that, you know, couldn't get into the office. And so I initiated a controlled substance on a televisit. But I, you know, documented why they couldn't be seen in person. Phentermine, I mean, I get it, it's a controlled, I don't think that's one that's gonna get you in a lot of hot water compared to like oxycodone and Valium and Xanax and things like that. But I think you can do it on an initial visit. If you're going to prescribe a controlled ongoing, I would say you best have a plan in the next 90 days for them to, you know, come in and see you. If you're doing like some nationwide, you know, medical weight loss thing where these people are never going to come in your office, I would be a little worried about that as a long-term, you know, strategy, because at some point, you know, they could sort of question why you're not, you know, examining people in person. I wouldn't lose too much sleep over phentermine. It is legal. Nobody said it's illegal to initiate a controlled over telemed. So we're in a pretty gray area right now. It's really about context, like I said, and documenting like why you're doing it as a televisit and that you have a plan for them to come in at some point.
Thank you, Dr. Rubin. Are there any other questions? It doesn't look like we have any other questions. With that, I just want to say thank you, Dr. Rubin, for presenting on such an important topic. This recording will be available on YouTube and on our social media platforms. Thank you, everyone. Have a good night.